noise. Anyway, today I'm going to talk about mainly management of tinnitus, and that is focusing mainly on a single dose therapy of injection chloroquine, particularly in a stage when it is launched by the company. Why I'm interested much is because I was actually involved in a double-blind randomized placebo-controlled study, which I did in 2000 before it came into the market. And when anybody tells us that okay, some drug is there which can treat tinnitus, cochlear synaptic tinnitus, and a single dose can cure tinnitus, so a lot of question comes to our mind: how a tinnitus years together can be cured in a single dose. There cannot be magic like this. And being a academician or people from science, we need to know the things. So here I want to convey and bring these facts under what concept, which concepts and which hypotheses and which proof, which convinced me that yeah, possibly this can work, and based on which I conducted a clinical trial. To understand that concept, it is necessary to know what is tinnitus. For this audience, it is not necessary to say, but different sensations or different descriptions are given by the patients are based on which area of the hair cells within the inner ear is damaged, and different descriptions of a tinnitus is there. And tinnitus could be which may be mild, or a patient, it may disturb the patients or it may disturb the hearing, and then usually the patient comes. But the severity of symptoms is such that in 22 years of practice, I came across at least 8 patients who did a suicidal attempt for these symptoms. So much frustrating for a patient, not only to the patients, for us ENT surgeons, we also get frustration because whatever efforts we do, we don't get consistent, successful results. And so this was a very important symptom to me too. Now, if you look to the classification of a tinnitus, we are not concerned with the objective tinnitus here. Subjective tinnitus, auditory and non-auditory, these are very rare condition. Gaze evoked tinnitus, patient looks to one particular gaze and he hears the tinnitus sounds. And cutaneous evoked tinnitus, scratching a skin on one particular area and patient hears the tinnitus sounds. And came across in this 22 years of span, about 4-5 such patients, and this is the highest. The irregular mismatch of this percentage is because of our patients having a simultaneous cochlear and retrocochlear, or a middle ear and a cochlear tinnitus together. So, but as you see here, cochlear synaptic tinnitus, the cause of tinnitus within the cochlea is the highest number of patients what we face, and that is a major problem. And fortunately, this drug today, which is claimed, is effective mainly on a cochlear synaptic tinnitus. So, if it really works, it is going to give us an excellent solution. This is just a slide to show the area of origin of a middle ear tinnitus, muscles which are responsible for it, and a cochlea which is responsible for it. Now, what was the concept based on which this drug came into existence? Professor Klaus Ehrenberg, is a professor at Vienna University, Austria. He gave a concept of a neuroreceptor mechanism which is responsible as a cause. I think you are coming in the way. And his concept was based on 3 facts: that glutamate is a neurotransmitter. These are the proven facts. Okay, glutamate is a neurotransmitter, not only in a cochlear synapse, all over the brain. 1, 2. There are 3 receptor subtypes in the cochlear synapses in the inner ear, and these 3 receptor subtypes are 2 ionotropic AMPA and NMDA receptors, and 1 metabotropic G proteins. And when a stimulus, these receptors are stimulated by glutamate, which is released in response to sound, and it creates a tuned interplay between receptors, results in a depolarization of a postsynaptic cell, and ultimately we hear the sound. But when this is disturbed, that disturbed interplay generates a different situation and patient hears tinnitus. I'll explain you a little in detail. And based on this hypothesis, he published a proof of this concept by an animal study. And after this, he conducted a clinical trial also. He thought of some molecule, he conducted a clinical trial, and in a European clinical trial we went through the results, and then we thought, okay, these results are acceptable, and we conducted a clinical trial in our clinic also. Now, to understand this, it does the shortening of frequency and intensity of the sounds and sends signals to the inner head cells. Now, in inner head cells, this sound energy is converted into a chemical energy and corresponding to the type of stimulus, intensity of the stimulus, corresponding number of glutamate granules, corresponding type of glutamate granules are released from inner head cells and reaches to the synaptic cleft. And this synaptic cleft, there is a postsynaptic membrane having a specific type of sub-receptors. Glutamate granules, when reaches here, it creates an excitation situation of these receptors, which generates a tuned interplay between these receptor subtype. And because of this tuned receptor interplay, a corresponding depolarization of the cell, postsynaptic cell occurs, and this corresponding depolarization generates an impulse which reaches to the brain, and we understand, we hear the sound. So this is a basic concept in a physiological situation. When glutamate granules stimulates the receptors and immediately gets dislodged, so that this receptor is now ready for receiving new signals to come. Now, in a pathological situation, when inner head cells are at fault because of some mechanism, the glutamate granules which release are either in excess or are toxic granules, and these toxic granules has a higher affinity for the postsynaptic membrane receptors. So when these glutamate granules comes in contact with these receptors, it generates a state of a spontaneous depolarization by way of persistently adhering to this receptor. Toxic glutamate granules, it comes in contact with the receptors and then doesn't get detached and remains there and generates a state of spontaneous depolarization, and which results in a disturbed interplay between these receptors and a state of a spontaneous depolarization, meaning by continuous generation of impulses, and that is how patient hears a tinnitus or a continuous typical sound of a monotonous sound. So this is tinnitus. What are causes why the inner head cell should be damaged? So all of you know these are the causes which results in a damage to the inner head cells, like noise exposure, local and general circulatory disturbances creating a ischemic condition, metabolic disorders of a general body conditions generating some toxins which reaches to the inner head cells and damages it, inflammatory reactions, mainly viral etiology of a middle ear, toxins released and by perfusion reaches to the inner ear, traumatic condition, hypoxic conditions, aging processes, and more important today we need to give attention is a free radicals. Because of polluted air inhaled, in a disturbed metabolic processes of our food contain free radicals, which contains free radical highly reactive electrons, unsatisfied electrons in that molecule atom, and these are called free radicals. When it comes in circulation in the body, it picks up electrons from the normal cells or normal atoms and it damages that cell. This concept is today accepted worldwide for aging, which explains aging process, which explains cataract, which explains arteriosclerosis, which explains certain cancers. And this is the reason why people started all over the world giving antioxidant therapy. So in an antioxidant we give vitamin A, E, C, so that it provides spare electrons to these free radicals circulating in the body. It satisfies these free radicals, and that is how it prevents damage to the normal body cell. So this is one of the major reasons possibly of damaging the inner hair cells. So because of these reasons inner hair cells are damaged. This is just a small video to explain the same concept in a simplified way, that how this happens and how this tinnitus is generated here. That this is a synaptic cleft between one nerve and another nerve, and a conduction is carried out by a chemical. When this synaptic cleft, which is a space between a beginning of another nerve fiber and end of one nerve fiber, And this cleft, when it is more than 20 nanometer size, it is called a chemical synaptic cleft, meaning by transmission will be by chemicals. Now, presynaptic cell having a bulbous end we call as a synaptic knob, which in a cytoplasm contains multiple vesicles containing glutamate granules. When any stimulus in the form of a sound, that impulse when comes to this presynaptic nerve cells, it results in a rupture of these vesicles and glutamate granules corresponding to the type of stimulus. Number of glutamate granules gets released. It reaches to the synaptic cleft and comes in contact with the receptors. It stimulates, it excites these receptors and immediately gets dislodged from these sites. And these receptors are now ready to receive another signal. But this excitation generates an electrical impulse which reaches to the brain and we perceive it as a different type of sounds. But in a pathological state, when because of a damage to the inner hair cells, the granules which are released are either in excess or in a perverted form, in a toxic granules, comes in contact with postsynaptic specific subtype receptors, remains adherent to the receptors. Instead of getting dislodged, remains there. And this is the reason a persistent state of a depolarization or a spontaneous state of depolarization is generated, and that is how we hear the tinnitus. Now this explains why some patient of a tinnitus having hearing loss and tinnitus, some patient they don't have. This depends on how many receptors are involved, but mainly if you observe, these all patients have a discrimination problem, because this involvement of our receptors, some of the sounds are skipped, some of the portion of our sound stimulus is skipped, and that is the reason why this patient has a mainly not a hearing problem but a problem of a discrimination will be there because of a persistently adherent receptors. Now then, what is the solution to it? If we can find out some molecule which is more potent, which has a stronger affinity for this receptor, stronger than a glutamate, one, if this, so a powerful antagonist to the glutamate, if it is able to reach to the synaptic cleft in a proper sufficient concentration, and it should be safe. If we find such molecule, then perhaps it can work. So by different type of like zinc, magnesium, and so many other molecules were tried, but looking to structural similarity of a caraverin with glutamate, it was thought as a perhaps it can work. And caraverin, fortunately, it was in use in European countries since 1960. Even today also, since last 50 years, it is used for a colicky pain in abdomen, spasmolytic. This is a drug in market in the injectable form. And a structural similarity, because of this structural similarity and equinoxylon dione structure, it was investigated for a glutamate antagonistic activity. A proof of this study was published in several international journals also. And later on it is developed as a therapy for a cochlear synaptic tinnitus. So this is a basic concept why caraverin molecule came in existence, and it was tried. So when caraverin you inject intravenously and this reaches to the synaptic cleft in a sufficient amount, because of a higher affinity and a strong affinity for our receptors, postsynaptic membrane receptors, it forcefully dislodges toxic glutamate granules. These receptors are now free for receiving another stimulus. This is heart with a ventricular fibrillation. Heart in a ventricular fibrillation, it just flickers, doesn't contract. If you give a big thrust on it, it stops totally, and when it starts beating again, it starts breathing. For a moment, it's blank, and then it doesn't remain adherent to it. It gets dislodged, and it is free, provided new glutamate granules are not toxic. So causality factor is not there, then it can give excellent results. So this is a basic concept of a drug, how it acts, and this also explains that how single dose can cure tinnitus, which is since long, the short duration, long duration, how it can cure. This caraverin, various actions of caraverins are studied by different pharma people, and these are the various papers published. It is an antioxidant therapy activity also. It is sometimes it acts as a scavenger for a radical oxygen species, and it is a potential recurrent gene inducer also. So because of multiple publications which are published in international journals about this concept, proof of concepts, and a clinical trial done in European countries. So if this is such a wonderful drug, we may think that we can have excellent results for a tinnitus. But word of caution here, that it is indicated only for a cochlear synaptic tinnitus. So it is necessary to diagnose perfectly cochlear synaptic tinnitus. And overdose may increase the tinnitus, even though temporary, but it may increase. So these two things, to avoid to take care of these two things, it is necessary to diagnose. For which, if you go this, these are the tests must to do. Don't do one test and stamp it as a cochlear origin, or instead of that, what? Like audiometry, if you do an audiometry 0 to 16,000 Hertz, you know patients of tinnitus may be with a hearing loss or with a normal hearing also. So in a hearing loss patient, if there is a sensorineural deafness, you can consider as one of the important factor to stamp it as a cochlear synaptic tinnitus. But in a case with a normal hearing level, if you do audiometry up to 16,000 Hertz, you will find that in a higher frequency, 8,000 to 16,000 Hertz, there will be a sensorineural deafness. And these are the cases where tinnitus is of a cochlear origin. Impedance audiometry, it is necessary to check compliance of middle ear pressure and a base pressure, base volume, to check it whether there is no any abnormality. Otherwise, a stimulating factor or a damaging factor is still there, and you push caravodin, perhaps you will be in a frustrating situation. Usage into function should be normal. Otherwise, also these are the two important factors which to rule out any abnormality. If it is there, you should treat it first, then go for jump on a caravodin. Acoustic reflex test helps us to find out retrocochlear origin and also middle ear pathology. Clinching reflexes. This is not mentioned in our book, so it is necessary to understand clinching reflex test. This is a test by which myoclonus tinnitus can be diagnosed very easily. If you do an acoustic reflex test in a low frequency, there is a 500 and 1000 Hertz, acoustic reflex will be noticed like this. Now you do an acoustic reflex test, ask your audiologist to do it with a clinching. So when acoustic reflex recording is done, then ask patients keeping same probe in a situation, ask patient to do a clinching of a tape and check, record the clinching acoustic reflex again in the same frequency. If muscles of the middle ear are at fault, there will be excessive deepening of a reflex will be found. So unless proved otherwise, this is a myoclonus tinnitus. So this is a very good test, clinching reflex test to isolate, confirm the myoclonus tinnitus. If you find such patients, either by I'll tell you a little later, but by a masking therapy or by hearing aid, these patients of a low frequency tinnitus, usually low frequency tinnitus is there, and they give excellent results. And in a worst situation, you can do a tinnitus with a tensor deepening muscle cutting. That also helps in the improvement in myoclonus tinnitus. For that also you need to confirm the diagnosis. Reflex decay test helps in diagnosing retrocochlear lesions, tinnitus matching and grading. Ask patient to sit in a soundproof room, give a signal different sounds of a different frequency from audiometer, and ask patient which quality of sound is matching with tinnitus what he hears. That is called matching of a frequency. And you find out then what frequency of sound he is hearing. Indirectly you are finding out which hair cells of which frequencies are damaged. And intensity, once frequency is confirmed, same frequency, you give a stimulus of a different intensity and ask patient to tell that you hear a sound of what intensity. So you can find out patient hears the tinnitus sound is of what intensity and what frequency. And these two has not only diagnostic value, like middle ear tinnitus are usually of a low frequency, cochlear synaptic tinnitus are usually of a higher frequency. So an additive factor to stamp the diagnosis as a cochlear synaptic tinnitus. But tinnitus grading has a prognostic value. While you give caravodin, not necessarily always you can have a 100% cure. Sometimes there are so many patients, even a patient who did a suicidal attempt, by pushing caravodin he found change in intensity. Some positive factor was there, which perhaps we were not able to diagnose, and when we pushed a caravodin injection, immediately it changed the tinnitus frequency and intensity, and then also patient was happy. So for us he was benefited. because a monotonous sound he was hearing which was torturing him, a little intensity is changed, little frequency is changed. He said, okay, I hear still a sound but I feel comfortable. So such benefit are also there. And some patients, they reduce in intensity, intensity in sound. So about second dose of carotid can be given or not, that also you can decide. So it has a specific prognostic value of our tinnitus intensity and matching. Tinnitus grading and matching. Short increment sensitivity index, CC test, which when we were studying, we were giving a lot of importance. Few years in between came that CC has no role, but everybody knows it, that short increment sensitivity index is a sign of a recruiting ear, which is a sign of a cochlear pathology. So if CC test is positive, it is more confirmatory for a cochlear synaptic tinnitus. If patient is associated with a symptoms like vertigo or some other symptoms, sometimes you may need to do electrostimography, BARA, ECOG, etc. But these are the rare situations which we need. But this is a standard test battery. One should do it systematically. You can definitely differentiate and cochlear synaptic tinnitus and use it. So diagnosis of cochlear synaptic is important, and how to use the drug. This is another issue. The ampule is available in the form of a 8 ml injection, which contains 160 milligram of a carotid. This is to be mixed with 100 ml of normal saline and intravenously at a rate of 2 ml per minute to be given. How much dose to be given? So till therapeutic effect is achieved or total solution is injected. Meaning by when you start injecting, there are patients after 10 ml, 15 ml of solution pushed inside and they say my tinnitus is gone. Then there is an end. You should stop it. But excess infusion may increase tinnitus. So to avoid this and to be very specific, we use a gradation system which we developed. We show this strip to the patient. Okay, this is a gradation strip. If your tinnitus is intolerable, you grade it 10. If your tinnitus is 0, you don't have tinnitus, you grade it 0. And now grade your tinnitus on your own. Okay, what is the intensity of your tinnitus? He may grade anything. He says my tinnitus is A. Okay, we say okay, your intensity or your tinnitus is A grade. When we push carotid, patient is to observe continuously that tinnitus sound, and he should say if it is reducing, he should inform us immediately. Usually they say okay, now it is 7 or 6 or 5, 4. When he reaches to the 2, between 1 and 2, we stop pushing more solution so that overdose is eliminated. Residual tinnitus, we can repeat sometime dose or some other type of therapy we can give, but overdose we can eliminate by this. So a standard gradation system should be followed, and this is a diagnosis of cochlear synaptic tinnitus. So this is how it should be done. Now, based on these criteria, we conducted a clinical double-blind randomized placebo-controlled trial. Even when I did it, I was not knowing which ampule contains normal saline and which contains carotid. And after results, we recorded all results of all patients, and then we were given that this number of ampule was with saline, this was with carotid. That is how sincerely and ethically we conducted a clinical trial, and we found good results. So for that clinical trial, this is a study design. I won't go in detail of it how, but all patients what we check is whether they mainly we check for we evaluated for efficacy and safety, and also we checked for whether patient or it is effective positively or negatively to the hearing also or not. So we found that there is no effect on a hearing by carotid because it is effective on specific sub-receptor type. Otherwise, glutamate is a neurotransmitter all over the brain. So question comes, and why it doesn't act any other places in the brain? But carotid is effective only on a receptor subtype. 3 subtype receptors are there, which is present only in a post-synaptic membrane of a cochlear synapses, and so it is not creating any side effect. Now in this clinical, while we push medicine, we take care that in last 7 days patient don't use such drugs which may directly or indirectly affect the results. So these precautions we took, and based on this we created a results and we found that 61% of the patients were responder. Now in this study, we considered responder who shows reduction in the tinnitus of a 3 or more grade, not necessarily absolute cure. 3 or more grade we consider as a responder, and a rest 39% were non-responder. We also tried to evaluate different demographic relations, like with a relation with the age, sex, then duration of a tinnitus, whether it is of a short duration or a long duration, onset of tinnitus of a sudden onset, gradual onset, whether tinnitus is only in the right ear, left ear, or both ear, with associated ENT diagnosis, whether previously treatment was taken or not, and what type of treatment taken, and has any specific relation with the results. We tried to check the associated problem history, like a hearing problem, acoustic trauma, sleep problem, vertigo, family history, etc. We found that Caravari result has no specific relation with any of the things. It is independently acting on a receptor subtype. It is giving independent results, and that can be explained by a specific effect on a specific sub-receptor type. If it is so much effective and so much potent drug, why these 39% are non-responder? And that can be explained by this, that different mechanisms responsible for tinnitus generation. Perhaps glutamate granules are in excess and your first dose is not sufficient to eliminate all the toxic glutamate granules. So it is recommended that if there is a patient who shows improvement, then but not cure, second dose can be given at after a week. 1 week interval should be kept. This is suggested by researcher. Exact logical reason behind is we can consider as a half-life period of a drug. So then mechanical trauma, when toxic glutamate granules released or some trauma to the hair cells, receptors are mechanically damaged, which is difficult to repair in a one shot of Caravari. May need a little longer therapy with Caravari, and for that purpose now gradually they are generating other formulations in the form of a tablet and Caravari ear drops. Likely we need a clinical trial of it, perhaps likely to come in the near future. Other endogenous metabolites like inflammatory conditions of middle ear and continuous diffusion of that is going on. So middle ear condition should be normal. Associated similar or different type of damage in a higher pathway. So combined lesions, cochlear and retrocochlear lesion, which perhaps in an investigative procedure we have missed. And persistent some systemic disorder, metabolic disorder in the body, which is gradually still continuously producing some toxins which are in circulation. Your Caravari perhaps is giving cure, but immediately that toxins again giving some damage. So these are the possibilities. Logically we tried to explain that why these 39% are non-responders. But then too, as a whole, significant positive results we found. Associated has no relation with any other associated problems. 6-month follow-up was strictly done in all patients, and we found persistent effect. That those who cured were cured. Few patients came back with the symptoms where we tried to push second dose of injections. Few of them responded, few never responded. But this was initial clinical trial, and Drug Control Authority of India gave permission of marketing based on our trial, plus multi-centric trial done in the European countries. But I strongly recommend that because it is now available in the market, we should generate a large data to have a real percentage of a cure in it. Because this is an academic activity. But that is definite that no serious side effect was not noticed, even though it is effective on glutamate granules. Desired long-term positive effect with a single dose Caravari infusion may be explained by that mechanism what I explained. And our results are consistent with other published, internationally published trials. So they are inconsistent with other results published. So this is a conclusion. So in short, today to a patient of tinnitus, there is no need to, because the number of cochlear synaptic tinnitus is the largest portion of a patient of tinnitus. So there is no need to say sorry to our patients that, oh, you have to live with it. In fact, one should not say, because all my 8 patients which I know who did a suicidal attempt, one or other colleague told that now you forget about any treatment, you will have to live with it. So instead of that, try to reassure. If you whether you use chlorine or not, if you use any other modalities of treatment, but don't say that you'll have to leave it, and it gives a real frustrating situations. But now with chlorine and other modalities of treatment, in fact in my clinic today I am able to give benefit to more than 90% of the patients. When results are 60%, why I am telling 90% of the patients? Because initially in 2002, with a permission from Drug Control Authority of India, I conducted a clinical trial. I was given only 120 ampules to do a clinical trials. And after that, I never had ampule. I cannot use legally. So, but large number of patients were coming to me. So I got a chance to do use different modalities of treatment. And at the end, I established a standard protocol of treating patients of tinnitus, and with this today I am able to give benefit to 90% of the patients, which of course if you use, I am very sure you will be able to give benefit to your patients. Like if you do a test battery, so you can perfectly diagnose different type of tinnitus. If myoclonus tinnitus is there, usually it is a low frequency tinnitus. It could be with hearing loss and without hearing loss. If it is with hearing loss, give a hearing aid will serve two purposes. Hearing is improved, and low frequency tinnitus are always masked with a hearing aid. So myoclonus tinnitus will be benefited by a hearing aid. Hearing aid should be a programmable digital hearing aid, where low frequency sound should be amplified little more than required, 10 decibel more than required. But if with a normal hearing, we give a tinnitus retraining therapy and tinnitus masking by readily instruments available for a tinnitus masking, or a tinnitus retraining therapy, which our audiologists do it. They call patients for a 3-minute sub-threshold level masking sound they give, and patient gets this is called a diversion therapy. There is a diversion of a brain's attention to the cochlea, and patient gets benefit for a shorter duration, and that duration is for some patients for a few days, for some patients for a few weeks. Again they come back and they sit for 3 minutes to 5 minutes in a audio soundproof room. They give a tinnitus masking therapy, and then patients will benefit. Gradually, those, not necessarily all patients gets benefit, but some of them who gets benefit, gradually the duration of a free tinnitus period is increasing, and after some times they are free of tinnitus also. So those who are not getting benefit with chlorine, in that patients we can use. Like, so what we were doing in a myoclonus tinnitus, we do a tinnitus masking. If patient is not affording, we ask them to do a tinnitus retraining therapy. If none of this works, for a resistant cases, we do a cutting of tensor tympanic muscles, and believe me, it works very well. It works very well. But simultaneously, before doing this, if any middle ear abnormality is found, which is responsible for tonic-clonic spasm of a middle ear muscles, then you should treat it first, which usually ENT surgeon ignores, which is observed. You may be doing it perfectly, but majority of the cases it is observed that finding out, like doing an impedance audiometry, acoustic reflexes, etc., to find out middle ear pressure and eustachian tube function test, we usually ignore, particularly in a patient of tinnitus. But instead of that, try to find out any basic pathology in a middle ear, and if you treat it, myoclonus tinnitus, you may give positive results. So if for a myoclonus tinnitus, if you follow this, you will give excellent results. For a cochlear synaptic tinnitus, usually it is a high frequency tinnitus. Again, with hearing loss or without hearing loss, normal hearing. With deafness, we recommend hearing aid, programmable digital hearing aid, and chlorine injection. So basic tinnitus, if chlorine gives excellent results, hearing improvement will be excellent. Otherwise, if with a tinnitus, if you give only hearing aid, patient will not be very happy, particularly for a discrimination, the mechanism I explained. Even with a hearing aid, they will have a discrimination problem. So if you remember, your patient with a hearing aid will number of patients, they complain of a discrimination problem, that the sound is loud but I cannot understand with a hearing aid. This is the reason that some of the receptors are not working. So if you push a chlorine injection and simultaneously start using hearing aid. With a normal hearing, only injection chlorine should serve the purpose. But if in both of this situation, if it doesn't respond, possibly because there are some unexplained non-responders are there. So with non-responder, we give a supportive medication. Now here important thing, which everybody can do it, Like all of us, we give vasodilators, vitamins, etc., antioxidants. But this protocol, we specifically with a logical reasons we decided we give combination of antioxidants, cerebrotonics, vasodilator and a microvasodilator. Vasodilator here, antioxidant, I explained the mechanism which is worldwide accepted today, a free radical causing damage to the inner hair cells, and if you give antioxidants, perhaps this is preventing the damage to the hair cells, and antioxidant perhaps helps a lot, and we observe that giving antioxidant helps a lot in improvement in tinnitus. Cerebrotonics, vitamin B complex, any nervous tissue regeneration, that is a necessity. Vasodilator, we all prescribe medium-sized vessel dilator like cyclospasmol, arlidine, etc. These are medium-sized vessel dilator. If you dilate medium-sized vessel and you don't dilate micro vessels within the cochlea, has no role. So you need to give a microvasodilator in the form of a calcium channel blocker. We use a synarizine more. So dilate a medium-sized vessel as well as the micro vessels and give a combination of cerebrotonics and antioxidants. So with these combinations, we find very good results. So the large number of patients without using any medicine also we were trying this. So what we decided, those patients who are non-responder here with even middle in a cochlear synaptic tinnitus, we give this combination and they are benefiting. Now then also with non-responder in a cochlear synaptic tinnitus, that group we send again for our tinnitus retraining therapy. So that area remains open. So all the possibilities, if you explore, you will be able to give positive benefit to more than 90% of the patients. And a few things about the future of caravarin, like based on a concept on which it was proposed for use in a cochlear synaptic tinnitus. It is also recommended for use in a sudden onset of sensorineural hearing loss, also for olfactory disorders. Right now we are conducting a clinical trial on it, but because of a confidentiality agreement, this molecule is from a PAFA company of Switzerland. It's a research molecule by them, and we are conducting a clinical trial. So more detail I cannot tell you because of a confidentiality agreement, but we are finding very good results. Only those sudden hearing loss dose required is in a bolus form, in a 4-time higher dose in a short span, and an olfactory disorder also it is effective. So in the near future it is likely to come. Other formulations, clinical trial with a placebo also we are doing it right now, because in our clinical trials we found some encouraging results in some portion with a placebo also. So to rule out that with a placebo, real result with placebo, we are still conducting that trial also. And a formulation of this drug for easy use. Tablet caravarin, as I said, caravarin is in use since 1960s. Since last 50 years it is in use in European market for colicky pain in abdomen. So tablet form is also available, but it is now only in 2 countries, Switzerland and Austria. It is in use for a cochlear synaptic tinnitus. About more than 1 million ampules are used there, and good data are available from there also. Now it is available in market here, so we will also be able to collect data from our patients also. And these formulations not available in India, tablet form and caravarin ear drops. So we are trying with an antiphoric method to push caravarin ear drop by perfusion, antiphoresis, by perfusion to the inner ear, and perhaps may give a good result. So instead of pushing IV, but this we suggested initially with a fear that caravarin pushing intravenously may damage some area of the brain. But now it is proved fact that it has no effect anywhere in the brain and absolutely safe drug. So this is about caravarin, and I will be very happy for any query, any questions. Frustrating situation, that's it. Like what happens? But in a patient there will not be no response. There will be no response only. Even I, with the same thought, tried in few patients, non-affording patients. What will you do? So push a caravarin injection, but as recommended by research, more logical and more effective. Because what happened in one of the centers, which was a sub-center to us, we also say with this argument, we said okay, push. so that we can have a little larger number of patients. They initially pushed randomly to 5 patients, and 4 patients were non-responders. So it was such a frustration that this is not effective. But then all 4 patients we investigated. 3 had a middle ear pathology. 3 had a middle ear pathology. Eustachian tube was non-functioning, and so what we need to do is, by doing this test, we don't say if everything else is major problem is of a middle ear, Eustachian tube dysfunction, you should treat it first. Cochlear and retrocochlear, as I explained, that patient usually will be benefited because there will be some change. Cochlear, if there is a combined cochlear and retrocochlear, there will be some change in intensity and frequency of sound. At least that will be there, minimum. And believe me, patients are happy with it. Some change, a monotonous sound, what they are feeling a tolerance, a monotonous sound, whenever they go to a silent environment, that same sound is irritating them. If you can change that frequency and intensity, then also that is giving benefit. This test. And once you sit and because now this list is given in your, I think, printout. Yeah, sabko diya? Yeah. So Eustachian tube test, even with a perforation, you can do it nicely. So all these tests, and logically, we also want to treat middle ear, make middle ear a normal functioning middle ear. So why not to do that and then treat it? So a real use and you will be able to understand. And we also wish that we generate a genuine data. So if negative results are there, we don't mind. If we should accept. If positive are there, we should accept. But let us go scientifically. We should not tell because somebody may try it. But sudden onset of sensorineural hearing loss, we are doing it. We give 4 ampule in 24 hours. 4 ampule, very safe. Till date, we found excellent benefit and no side effect. But don't try it, please. Because this what we are doing is with the permission from Drug Control Authority of India and specific conditions, specific precautions.
What preparation should be? How should we be prepared before
monitoring? Nothing. Only anaphylactic reactions like any other drug. You don't need to have anything specific.
It is given as OPD treatment, or you have to admit?
No, normally because in a 2-hour span, you should, to be on safer side, keep under close observation when you are in consulting. Sit there and ask, so that you should be available to know when patient says that my tinnitus is reducing.
Any other monitoring required? Pulse, BP?
When we did a trial, we did everything like cardiac monitor, pulse oximeter, everything we are on, NIBP, everything we were keeping it on. But now we don't do anything, and nothing is there. So, but even that patients, in few of our patients, some change in intensity, it helps. Some change in frequency, that gives patients that okay, it's better. Theoretically, we check. There was you can try this in such patients. Those patients who feels better, send them for again an investigation. You will be able to notice that frequency and intensity matching when you do, you will find there is a now change. Before pushing it, you try twice, thrice. This is all what we did. It comes same. Tinnitus patients, today you test, his frequency is 4000 Hz. Pushing it, there is significant change. Those patients who gets benefit, there will be evident change in the intensity and frequency. So for that purpose also it will.
So one thing is established as a central tinnitus. So if you are, even if you do 8th nerve section or if you do labyrinthectomy, tinnitus cannot be eliminated because the lesion is no more in the cochlea. So in your statistics you have shown that 70% is cochlear synaptic tinnitus. So I mean, have you taken this data from somewhere? I would want to know, because only initial phase, say 1 to 2 month period, when the tinnitus starts off, it is cochlear lesion. So that is the only time period you have. And most of the patients which come are usually 6 months, 1 year, 4 years, 5, 10 years. So in them, even if you do anything for cochlea, it's not going to happen.
What you are telling is what we should do.
Yeah.
So normally intensity is reduced because of a correction in the cochlear area. His tinnitus was a combination of a central and cochlear origin. So change in intensity and a reduction in intensity and a frequency, change in the frequency gave him benefit, right?
No, what I'm saying, it may be reverse. or even more than that.
So in that case, they must be
mostly up to 90% of the tinnitus is central. It is in the auditory cortex.
When you do this test, you can definitely by doing reflex decay test. If reflex decay test is positive, we stamp it as a retrocochlear lesion. But CC test is positive, we stamp it as a cochlear origin.
No.
Right?
Cochlear origin has been there.
When I looked left, he gets tinnitus. This was typical patient. Video recording also of that patient. But there are some such like scratching of skin patient. Typical. Whenever he scratches left arm, he gets tinnitus. So something funny, but cannot explain.
Hospitals, I Ramesh Chaturvedi.
Express a sincere vote of thanks to the leading dignitaries of Lucknow city. In fact, I am really very much grateful to Dr. Kandar, who has given his very precious time and he has come all the way from Ahmedabad to our city and he has graced the office. I am sure that you all have enjoyed the program and the talk was very informative. I am also very much grateful to the Association of Lucknow City, especially Dr. C.V. Pandey and Dr. Manoj Kumar Gola, who has inspired us to conduct this program. And I am sure that your presence is boosting our confidence. In the coming future also, Lincoln will be always with you for conducting such type of CMEs. Thank you very much. So kind of you. And now I request to all of you to